Our next speaker today is Simone O'Brien. She's a nurse practitioner who has spent over 25 years working in rural health across acute, emergency, aged and community care. She previously worked as a forensic nurse examiner for the Victorian Institute of Forensic Medicine, travelling to Victoria to assess and treat victims and perpetrators of crime. On a personal note, 2019 was a big year. Simone was diagnosed with a malignant melanoma and had surgery on her right leg. 6 months later, she had a slip and sustained a significant broken left leg, requiring 2 surgeries, a lot of metal in her leg, and 6 months off work. Simone spent much of this time studying medicinal cannabis, how it works and what's happening around the world with legislation and access. She has since undertaken several courses in prescribing medicinal cannabis and is passionate about patient access to cannabis as medicine. Please welcome Simone, whose presentation is titled Medicinal Cannabis in a Rural Community: Discussion and Case Stories.
Hello everyone. Half the room's left, so it sort of makes my job a bit easier. I'm a bit nervous about standing up here. I'm not an academic, I'm not a researcher, I'm a clinician. And also I'm a country nurse, so I probably talk a bit differently to all the clever people who've been up here today. Okay, that's me. So I work pretty much full-time in cannabis these days. There's probably only about 1 day a week where I don't do it. And that's because I need to do some other work as well. So if you're wanting to find me, that's where I live. I work in private practice in Bendigo, and I work 3 days a week at Heathcote, where we've ended up setting up a MBS-funded cannabis clinic in a tiny little country hospital, which I'll talk about. So that's Heathcote on the left, and that's my clinic on the right. I've deliberately got a clinic without desks. It's just 2 sofas, very casual, relaxed environment in my private practice. And that's because usually by the time the patients get to me, they've seen every specialist that they can possibly see. They've seen a lot of doctors. They've been in and out of the medical system for about 10 or 15 years. Nothing's really worked for them. They're exhausted, they're angry. So we usually just sit and chat, and they tell me their story. I talk about cannabinoid therapies, and we take it from there. At Heathcote, what we've ended up having to do, because there's such demand in the community there for cannabis, we had an opioid crisis about 2016, where we got extra funding for a drug and alcohol nurse practitioner to come and work with us for 2 years to try and exit some of our patients off opioids. So it was a real problem for us in our town. We had, there was a lot of misuse of opioids, a lot of opioid diversion. So we had to work at a community level, and we worked also at a health facility level to try and stem that. And obviously when you take people off their opioids, if they've had a long history with opioids, they need something else. So there was a big gap there. And what we saw happening was that a lot of these patients actually turned to heroin, which created a worse problem. So what has happened over the last 12 months at Heathcote is we've ended up setting up, it's now 2 days a week, an MBS-funded clinic on a Wednesday and Thursday, where if you live in Heathcote or in the surrounds, we're a rural area, we're a large farming area, then you can access medical cannabis free. The cannabis obviously isn't free, but the appointment with the clinician's free, funded through Medicare. So in an outpatient clinic type model. And I think we might be the first hospital that's doing that, but I'd love to hear if there were other hospitals that were. Okay, who do I see? So this is a really important distinction. Often people will say to me, oh, are you a specialist in pain? Are you a specialist in palliative care? I'm not a specialist in palliative care. I'm not a specialist in pain. I like to say I'm a specialist in complex people. But for nurses, we're treating the endocannabinoid system. So I say that to patients. I'm not treating your pain as such. I'm really treating your endocannabinoid system, and then that treats your pain. So when we re-regulate that and adjust that, that will treat your pain. So the types of pain people I see for cannabis, the ones listed up there, and I've got some patient stories, I'll take you through them shortly. So pain and probably mental health are the two predominant types of patients that I see. PTSD and anxiety probably being the 1 and 2 out of that. I have with some of my patients, and I haven't included their stories today because I'm mindful that it's being recorded. I have got some patients that are survivors of institutional sex abuse and things like that, with quite profound trauma that cannabis has changed their lives for, profoundly changed their lives. They can leave the house, they can do things like this. So I've seen it work spectacularly in some cases. The criteria to see me, I say you have to be over 18. I do have some patients under 18, but I will only work with the underages if their specialist or paediatrician is agreeable to it and not a cannabis prescriber. So I'll say to that person, you've got to go and talk to your ped. If they don't prescribe and they're happy for me to take over your cannabinoids or your ECS, then I'm happy to do it. But that's all I will be managing. Your ped, your specialist, whoever will manage the rest, and I'll just do your ECS. And that's a really nice way, simple way to think about it. If you're interested in getting into cannabis nursing, then try and keep it like that, that you're not sort of treating, you don't have to be a specialist in MS and you don't have to be a specialist in pain and things like that. It's more about that endocannabinoid system. And that's why it needs to be in nursing training, and we need to learn more about it. So I say they have to be over 18, but I do have some under 18s with specialist input. I can see people in person. I see them in person in Bendigo, Heathcote, and also do telehealth all around Australia. I've got patients that are actually coming to this conference today from different parts of Australia that have said, oh, good, I'll finally be able to meet you. I do a mix of private and bulk billing, and I do most of my bulk billing, most of my follow-up is bulk billed in my private practice because I want to make it accessible, it has to be. So I usually say I'm pretty much a one-off cost, a startup cost, and for most of our follow-up, if there's something weird or wonderful I have to do, there'll be a charge, but they get a rebate for that. I always insist that they have a referral too. And that's mainly because I want the patient to actually go and talk to their doctor about it. And I want them to engage their doctor. And the patient's a great one for educating doctors. I've seen changes in GPs over the last 2 years. I've been prescribing cannabis for 2 years. There was a lot of hesitancy to refer initially because GPs didn't believe cannabis worked. The GPs that I work with at Heathcote are very used to it now, so they just refer quite happily. I get referrals from doctors all around Australia, specialists in the big hospitals. So I make them talk to their GP specialists just because it has to be collaborative. We've got to have a team approach. Patients need a team approach. You need more than one provider. A lot of my patients, as I mentioned earlier, are quite complex. They're people who have, and the stories I'll talk about will illustrate that. They're people who are really, some of my patients are very angry. They're very angry that they were put on opioids. They were very angry that they were taken off opioids then 10, 15 years later and then told that they were addicted, that they had to go on to Suboxone, that they had to see drugs and alcohol. So there's a lot of, in the patient populations, and I know you guys will have seen this because you're nurses as well, there's a lot of anger out there at what a shit job we do, basically, with our medicines that we offer. So having cannabis in my toolkit has been the greatest tool I've ever put in there because it actually works and it helps these people. And I've seen these people who have got long lists of medications, whittle their medications down, get their lives back. My approach is I work with them. I say to them, I'm going to walk the journey with you, especially for the first few months, because most of my patients, well, these days it's probably, the demographics change. These days it's probably 50-50, but initially it wasn't. 50% of my patients are probably cannabis naive, don't know anything about it, don't even understand the difference between CBD and THC. So it's quite intensive for those patients. We walk the first few months together, but my ultimate goal is to get them dosing themselves. I don't believe that I should be, you know, if they're capable of doing that responsible, then they should be dosing themselves. They should have a plan for days where it's bad days and a plan for a normal day, and then they sort of have limits that they can go between. That's my philosophy with it. So a lot of my work is transitioning people to cannabis off opioids. I've got the next two slides on illicit users, and this is, you will have all come across people who use cannabis recreationally. I have a lot of patients that come to see me because they want to swap from illicit use to medical use. These are probably my most vulnerable group of patients because they've been accessing illicit medicine for years. They don't know what they've been smoking. They know that some strains work, some don't. The quality of their cannabis is very varied. They often end up with hyperemesis because they're inhaling stuff with chemicals that have been sprayed on it. So my illicit users, and they're wanting to basically sharpen up their act, sharpen up their cannabis, swap over to a regime that's medically managed and where they can use their strains to control pain, anxiety, whatever's going on for them better. These guys have faced real stigma in the past. They still face it whenever they enter hospitals because they use cannabis. I would love you guys to leave here and just when the only thing you have to say to these people, and they'll know exactly what you mean, they'll answer it every time you ask them. The only thing you have to say to an illicit cannabis user is, oh, what are you self-treating with that? Because they'll have an answer for it every time. Those ones that have been on it for years are treating something. So I want you to really take that away from today. If you're coming across, if you're admitting people for theatre, for wherever, and they're using illicit cannabis, ask them, what are they self-treating? And then if you can steer them into a clinician, that whether it's a local clinician, whoever, that can then perhaps get them onto medical strains and just tighten up their regime a bit. They're really great patients to work with. The other one, did anyone see this last week on SBS? Oh, you all have to go home, and not tonight because you'll be at the drinks, but maybe over the weekend. I really encourage you to watch this one. It's still on SBS Catch Up. It's just mind-blowing. Talks about cannabis, but it also talks about psychedelics, which I won't go into here. But that's our next step, next battle as well. So if you can watch this one, you will learn so much. You will take so much away from it for your patients. Okay, I'm going to tell some patient stories, and I'll probably have a bit of time at the end, hopefully, for some questions if anyone wants to yell any out. Okay. I'll first tell my patient story. So in 2019, I tell my patients this is my dickhead injury. So this is completely my fault. I'd had a very busy day at work one Saturday at work. I hadn't eaten much, knocked off, went over to a girlfriend's house, another nurse. We got out the red wine. I was still in Crocs, didn't eat tea, just wasn't that hungry. Left to run down to the taxi down the hill on a wet, slippery, rainy night in Bendigo and got a lovely skier's injury. So, except I wasn't skiing. So that changed my life. So this was 2019. Prior to this, my brother had moved over to Ireland and set up cannabis dispensaries over there. So I had some sort of background knowledge in cannabis. I hadn't used it since I was an undergrad. But it sort of thought, oh, that's nice you're doing that, JP, but I've got no real need to use it. I don't need to use it recreationally. So I didn't really use it. Then this happened. So that was what I was on. I was off work for 6 months, was staged back to work. I still get a lot of pain in my leg. If I sit down for too long, I hobble. So I was on all of those meds. I was home. I had multiple surgeries. I've had bone grafts. I was home without traction on for 2 weeks. My partner's in the room and had to look after me with all of that happening. And so I've got a lot of metal in my leg. The next slide will show you how much. So in about a year later, after this had happened, I went back to the surgeon who I know. He's got a nurse practitioner, he knows me. So I thought, oh, this will be really easy. He'll be able to just take this metal out for me. It's driving me nuts. So I went back to him thinking, oh, it's a done deal. And he said, nope, Simone, suck it up, learn to live with it. It'll be taken out when your leg's amputated. And then he said, oh, I know, I'll put you on an antidepressant and we'll start you on some NDEP. No, I'm already on too much. Nope. So I went home and practiced what I preached, or practiced what I'd learned. So I went from that to, I put myself on, my current regime. Yep, I use CBD at night. I used flour. I used oil. I made my own butter. I tried everything. I had relentless pain. I tried everything. I bought machines. Did it in stock pots, everything. Bought it illicitly. I eventually, after testing everything, settled on this, excellent for pain. I found that this strain is also excellent for appetite suppression, just as a FYI. On my bad day now, I just add in Panadol and aspirin, really. I still probably think about once a month I could do with an opioid because the pain gets really bad, but just haven't gone there. Okay, I've assembled 6 examples of patients. There's only 2 slides per patient, so I'll try and whiz through them. I won't read the slides out, I'll let you read them. I'll just talk to the patient. I've tried to pick 6 examples of different clinical presentations. This first patient, this is a really good example of how osteoarthritic pain responds. I see varied results. Osteoarthritic pain can be hard to treat. There can be varied results. I see better results with the autoimmune type pain, with your rheumatoid arthritis and things like that. They respond really well, really quickly to low dose CBD. So this lady, as you can see her history there, I won't read it all. She sort of gradually had, over a couple of years, she'd really reduced her activities of daily living. She didn't do much. She said, I put on a lot of weight. I'm just not doing much anymore because of pain. I sit around. Came to see me. She was cannabis naive. So I started her, she was part of the Quest trial. I was one of the prescribers for a trial done with Little Green Pharma, Quest. So she was one of those participants. I popped her on some CBD. So quite low levels, as you can see there, only 10 sort of, we got up to about 20 milligrams within 2 weeks, and a 10 at night because she had quite significant bony pain. And often the THC is needed. Sometimes I'll start CBD and then introduce THC a couple of weeks down the track, but I think with this lady I started it all first up, so I thought she's going to need it. She's got quite significant pain. So that's what medication she was on. And then when I called up with her 2 months later, and I emailed her last week, I emailed all these patients just before I came to say, hey, I'm going to be talking about you. Is that okay? Can you, and they obviously gave me permission. They gave me quotes too. So there's a quote from her. So what she's settled on that regime. When I say I get them to dose themselves. So what I'll often say with these patients where there's no risks, no red flags, is I give them a range. And I say, anyone who's got chronic pain knows they'll have good days, bad days, really shit days. So I'm dosing them, okay, what type of day is it for you? And we try and keep it really simple, and I just do what you could call surge dosing, breakthrough dosing, whatever you want to call it. So her medications have changed, obviously, since she's been on the cannabis. She said, Simone, I'm back out in my garden. It's just, love it. It's fantastic. My life's changed. This is a plumber, a fellow. Quite significant anxiety and depression. He was one of an unusual one in that most of the anxiety and depressions that I'll see will have a traumatic sort of trauma in their background. This fellow doesn't. He was diagnosed at 16. He commenced on heroin when he was 16 and then weaned, was on methadone, Suboxone, blah, blah. He has used illicit cannabis since he was 16 as well. So had a dealer in Bendigo, didn't really like his dealer, thought, you know, he thought the dealers are not nice. And really struggling getting consistency with strains, that kind of thing, and couldn't grow. So he was a grower. He used to manage his own. So he came to see me. Transitioned him over to legal strains and strains that would actually help his anxiety and depression, looking at the phytocannabinoids that will actually be a benefit to him. So he's still on his Effexor, and I suspect he will probably never go off it. But his life has improved. He's got a new girlfriend, he's working better, he's attending work more, his mood's better. And as you can see there, he's had quite a few strains that he rotates through. And you'll see that quite a bit with patients who experience cannabis users, and I'd put myself in this group as well, in that you may have at home 4 to 6 different tubs of cannabis. And for me, as an example, I'll think, oh, I'm gonna, you know, these two are my ones for now. And then when I'm a bit tolerant to them in a month or so, I'll put them at the back of the cupboard and get the other 2 out that I'm not as tolerant to. Because your THC receptors, you can become tolerant, as in it has less effect. So you often see those people, everyday cannabis users, don't really get stoned. I don't get stoned. I wish I could get stoned. It'd be a lovely feeling. But I don't. I could, sorry, question? Oh, I can't. Yes, the percentage is the THC. So this is a good example. In the Beacon Cold Creek, which is 25%. Now that is an excellent, excellent strain. But I say to my patients, you're completely mad if you use this beyond bedtime. You only use this one at bedtime, because if you use this all day, every day, well, you're not going to get off the chair, and you're going to just burn your receptors. You'll become so tolerant, nothing else is going to work for you. So you might as well just keep this one for your nighttime strain, perfect for sleep induction, perfect for pain. So I tend to, and the experienced cannabis users are good with this. They know their percentages, they know their flower, and they'll mix it around. So that's a good example of, how the flower side of things work. So this is a lady I saw in Heathcote. She had quite a significant work. She was a cleaner, quite a nasty back injury, with quite long-term pain, lots and lots of medication. When I met her husband had left. She was very flat, very depressed, presented with a mum came for the appointment with her elderly mother. She really struggled adjusting to a permanent injury because she can't work anymore. So her whole life's different. So she came to see me to see if cannabis could help her at all. That's her quote from last week. I got her onto CBD and THC. What have I said there? Oh, the oils. I find with people with complex pain, significant pain, it can be a little bit tricky to hit the mark sometimes with the THC oil because it's slow onset, it's long acting. So that can be a little bit trickier to play with sometimes with the pain. The flower works an absolute treat because it's immediate, it's short acting, they can vape it. This lady was a tobacco smoker, so it wasn't a hard concept. I don't tend to introduce flower to people who perhaps initially, if someone was cannabis naive, I wouldn't introduce flower at the first appointment. I'd step them right through the oils first, get them to what I would see as, oh yeah, I reckon you're therapeutic with oil. Would it benefit adding in a PRN, which is the flower? I talk to them about vaping. A lot of the illicit users still use bongs. I get them to, yeah, they all do, all joints. So I talk to them about that the end goal, a lot of our conversations are ongoing, and I say to them, the end goal is if you're going to use cannabis, if you want cannabis for the rest of your life, we have to make it healthy. How do we get you off that bong? Let's move to an 80% bong, 20% vape. Let's do that for a while. All right, good. That's working. You like your vape now. Let's get down to 70-30. And I try and wean them that way. They're probably never going to throw their bong in the bin, but I like them to be honest and to tell me, yeah, hey, oh, look, I have a cone at night because, you know, this or that. I think honesty is better. Okay, so this lady, she responded really well to, again, the Little Green Farmer, the Desert Flame. Excellent, excellent strain for pain, that one. And some Jasmine at night. She was cannabis naive. So her medications have changed significantly. She self-weaned these. So she just did it herself, which I nearly fell over when she told me she'd self-weaned gabapentin. But she did. She's very happy. She's now down onto Panadine Fort and she's looking at weaning off that, but she's a long-term Panadine Fort user, so she wants to do that one quite slowly. Okay, this is a young fellow I have, again, long-term illicit use with this young boy. He's given me a lot of quotes to use because he's very passionate about cannabis because it's the only thing that has helped him. I've used his story because he's a really good one to show how the stigma of cannabis can affect patients profoundly and can really make their lives difficult, travelling, things like that. So there's the quotes he gave me. Having his cannabis medicalised, he's been able to manage his pain. He's what I would probably call, sounds funny, but a sophisticated cannabis user in that he researches his strains, he talks terpenes, he talks cannabinoids with me. So he's quite good, he's quite sophisticated in his knowledge. So that's the meds he was on. And so when I contacted him this week, he has told me this. He lives in the Northern Territory. So again, further barriers if you live in the Northern Territory and you want to access cannabis because the mail's so slow. There's few chemists that do it. You have to get it from interstate. So it's been, for him, having someone that he can email and say, hey, I've got a question, or book an appointment and say, hey, I want to talk about my cannabis. For him, it's changed his life. He said, I feel legitimate now. I've got more confidence. I feel okay traveling with it. I don't feel that stigma that I'm a drug user. Okay, Craig gave me permission to use this photo, so I did. He's a fabulous guy in Heathcote. He was a social worker during the Manus Island riots. He's got quite profound PTSD. He saw a lot of violence up there. How he got onto me was a friend in Heathcote had been giving him, supply from the green market. And he said, I'll show you what he said there. Oh yes, the cured my ADHD. I felt a bit like that too when I first tried cannabis. I thought, I think I've got ADHD. My brain's working normally now. So he felt when he started using cannabis, he said, it settled his anxiety right down. And he was also self-medicating with alcohol, which we see quite a lot of people doing. He's also lost a lot of weight. We see that in long-term, I've seen that a little bit in long-term cannabis use. I do think it depends on the chemovar, but long-term cannabis use, you'll see if you stabilise the ECS over a period of 12 months, 2 years, people will stabilise their weight, their blood sugars will stabilise, a whole lot of things will change. So he's naturally changed shape. I've got a few patients that have done that. Their shape just re-regulates over 12, 24 months quite naturally. So he's on a few strains that he rotates through and just manages them for his PTSD. Last one, and I'll quickly, I've saved her to last because she was just amazing. The nursing home girls were thrilled with me with this one. So they're a patient in our nursing home. She's got quite an extensive abdominal history. Now, aside from that history, she's also got the usual history of a 92-year-old IHD, all that, the COP, all of it. So she was developing worsening behaviours. We suspected it was abdominal because of her. We suspected she's got pain because of her abdominal pathology. Now, I don't stick my nose in unless I'm invited. So I'd sort of been watching this as I was treating other patients in aged care. And over a couple of weeks, and then eventually the GP said, "Simone, can you start some cannabis for her, please?" So I went and saw her, and she's got this quite an extensive abdo history, and I thought, initially what I did first was send her off to Bendigo Health just to exclude, because the family were wanting active treatment, to exclude that there was an actual pathology there. So we did that. There wasn't. And came back. She was literally no response to morphine, Medaz, any of that. They were really at the end of their tether. I started her on I suspected she probably would need a decent dose of CBD. So I went with the Antura, the CBD 20, did 3 drops TDS. So she's had a massive change. She's like a different person. There's no more calling out. Her behaviours have settled right down. She sleeps. There's a little bit of agitation at night, which I will, when I get back to work next week, I'm going to be looking at putting some THC at night because they want to wean the Rivotril. But we've managed to, her behaviours have completely settled. Her pain has settled. The girls in the nursing home tell me that her bowels are beautiful now, completely regular. Family are very happy, and she's like a different person. And that's just with CBD alone. That's a really good question. I was just asked, do I get pushback? I will get to that because that's a really good question. And yes, I've been called all kinds of things. So this is pretty much my last slide. That's just some take-home points you can read because I do want to answer that question. Yes, I have had pushback. There is a GP. Some GPs have told some patients that there is a GP in Heathcote that works for his anti-cannabis. And he has told patients that I am a witch and that I prescribe witch medicine. So I've known this GP a long time, so it's like, it doesn't worry me. So yes, there is. I am lucky that where I work in Heathcote, that none there, very supportive, they know it works. They will actually reach for it. And I think why I really do believe nurses are the ones that are going to take this cannabis forward. And the reason being, there's a few reasons, but certainly from the medical colleagues I work with, they're not wanting to take on prescribing of cannabis because they have enough to do. They're quite happy to refer a patient to someone who prescribes cannabis though, and then have the external clinician manage the cannabis. I think we will eventually move more towards that. But yes, you do get some pushback. I just figure I'm old enough and tired enough to handle it.